Hello, I'm Sheryl Lewin, and today I'm going to be talking to you about innovations using 3D technology for microtia treatment and what led me to develop a new technique using customized 3D porous implant ear reconstruction. So since I'm just a tiny person in the corner, this is me. And to introduce myself briefly, I just want to start by saying that I think I am the luckiest and happiest surgeon you will ever meet. I've just been blessed with the most rewarding career, incredibly challenging, and it's led me to a really wonderful place. So pretty much every Tuesday, Thursday, and Friday, I get to build an ear. And I never would have predicted that I would spend my professional life creating ears, but when I do look back on how I got here, I can sort of see why it makes sense that I'm doing exactly what I was meant to do. So these are two drawings I did when I was 19 years old. They were assignments for my very first architecture studio in college. And although I went on to get a degree in architecture, when I look back at these drawings, I started to see just the slightest hints of my current career. Even way back then, I was very fascinated by human anatomy, and somehow this appreciation managed to find its way into my architecture projects. So this image of a male figure on the right is actually a rendering of a statue by Auguste Rodin called Adam. And I noticed when I was looking closely, I even chose an angle that showed his ear. So tiny hint, but you never know. So in college, I planned to be an architect, and the definition seems quite obvious. But when I was about to graduate, I felt concerned that designing buildings, much as I love the creativity of it, might not be what I wanted to do as my career. But I noticed there was a second definition that maybe pertained a little bit more to me. And that's when I decided that if you just changed one letter, you get Earchitect, which I think perfectly describes me, because sort of over my career as a surgeon, I've come to appreciate how much my art and architecture background has really enabled me to innovate and design how to make ears. So after medical school at Stanford, I did my plastic surgery residency training at USC, and then a fellowship in craniofacial surgery at Children's Hospital, which was highly emphasizing ear reconstruction. And then I went into a practice both at Children's and at Cedars-Sinai for 7 years. And then in 2012, I started a private practice that was just dedicated solely to ear reconstruction. So today, about 95% of my practice is spent performing ear reconstruction for microtia. And we know microtia is a spectrum, and we know that you can have just a small, slightly malformed ear to no ear at all. And surgeons often use a grading system that you see here to describe the type of microtia a patient might have. The most common being grade 3, where you just have a little bit of an earlobe and a little cartilage above it. And then the most challenging being anotia, where you have no cartilage, no canal, really nothing at all. And in terms of the cause, there is a thought that both genetics and the environment play a role in the cause of microtia, but how these factors work together or how much each is involved is still largely unknown. Most of the microtia cases that we see are actually called sporadic, and that just means there's no prior family history of having microtia. So I give this slide in every lecture because I just think it's very important what I'm about to tell you. And I'm amazed because it is so universal, this concept of parental guilt. And it really doesn't matter what country I'm in or talking to. There's just this common but totally unfounded belief that some things maybe a mother during pregnancy did something to cause their baby to be born with microtia. And I'm just here as a physician and a surgeon and someone who looks at evidence in science to tell you that absolutely nothing that a mother did during pregnancy caused your baby's microtia. There are very, very few things that actually you could take during your pregnancy, very rare medicines, but that is so, so rare that in almost all cases, it just happens. We don't know why. And I feel it's best to just let that guilt go and just focus all your attention on what to do now, if anything, to treat your child's microtia. So in terms of microtia treatment, there are many options, just similar to oral atresia. So it can be quite overwhelming. So specifically for microtia, you can do nothing. You can do prosthetic ear, a rib cartilage reconstruction, a two-piece porous implant like MedPor, or a Supor customized 3D implant, which is what I do now. For oral atresia, you can do nothing if you're unilateral. You can also do any variety of hearing aids that are available now, or you can do canal surgery. So for today, I'm going to focus on microtia and the visual goal that we're looking for, oral atresia obviously being the functional goal that you also need to consider. So here is just an average ear. And in case you didn't already believe, the anatomy of the ear is incredibly complex. This anatomic description or illustration of the ear will definitely convince you that every single nook and cranny and fold of cartilage, has a name and a proper form. So that's sort of why we believe ear reconstruction is considered to be the most challenging procedure in plastic surgery. But it's really important to remember that it's not just an ear that we're thinking of, because so many of these patients have hemifacial microsomia. And in the mild to the severe, you go from basically a challenging surgery to an extremely challenging surgery. So what is the goal of ear reconstruction? This is going to sound odd, but it's really that no one ever notices your ears. That's my belief. So here's a young girl. She's a patient of mine, and she was not born with microtia. And I bet when you look at her right now, you wouldn't think twice about her ears. You just sort of notice her beautiful face. However, this is not the way she looked when I first met her. And in fact, the reason she came to me is because she was very concerned about how prominent her ears were. And it really affected her life in a significant way. So we were able, in just a few hours in a little outpatient surgery, to just tuck back her ears, called an otoplasty, and be able to help her just move on so nobody notices her ears. So here's a little boy who clearly does have microtia, but the same concept, I think, applies. We want to do a surgery so no one notices his ears. So after his 3D ear reconstruction, you can see that yes, there's certainly probably still asymmetries that are visible, but overall, when you glance at him, I don't think you really notice anything but that gorgeous face. Here's just a side-by-side to see the difference. So I also believe that making ears is very much like creating a sculpture, and clearly as much about art and creativity as it is about technical skill in the operating room. Some surgeons believe that since the ears can never be, directly seen side by side in a person, that reconstructing ears does not require a mirror image be created or an exact replica. And in fact, some would even say that pursuing that goal is actually excessive or too expensive or perhaps just unnecessary. However, I have a different belief. My goal is we would like to create the most realistic and symmetric ear possible. And so here's an example of one of my patient's ears. And granted, I could never make a perfect replication of this, but that's going to be my goal each and every time. And that's what drives me to keep getting better. So I don't think before this technology I'm going to show you today of 3D ear implants that I would have been able to get a result that looks as symmetric as this. So when I finished my craniofacial fellowship, which was in summer of 2005, Children's Hospital had so many microtia patients waiting for surgery. There was literally like a 2-year backlog. And those kids had to get cared for. So I ended up taking care of a lot of those patients. And it basically created this amazing, unique situation where I was able to focus, and I would say obsess, on ear reconstruction. And in those years, it's been basically 16 years, I have been pretty obsessively thinking about how to take this technique and do better than we've done. And so basically, I don't do anything the same that I did when I was in my training. Now, after about 1,200 Microtia reconstructive surgeries, I'm now able to trace my own learning curve. And I can tell you that in 2018, which was when 3D technology came into my practice, that was a complete game changer for me. And today I'd like to just spend a bit of time explaining sort of where I started with ear reconstruction and where I am today. So I found a process that really has helped me improve my results. And that starts with basically critically analyzing what isn't working. And to do this, I clearly have to be my own biggest critic. But the second part is to put tremendous time and energy into solving the problems that I see when I'm trying to move things forward. So for the first 12 years of my career, I used a standard implant, and that consisted of two pieces, a rim and a base. And those were made of porous polyethylene, and you basically melted them together, and that created the implant, which is commonly referred to by a brand name such as MedPor or Supor. I will use the term PIER throughout this talk, which stands for Porous Implant Ear Reconstruction, because you're not necessarily referring to any specific brand, but just the type of technique for reconstructing ears. So here you can see that we used a heated pen, and it melts those pieces together in order to create the structure of the ear. But I became frustrated when I saw the limitations and the flaws with this design, and that I wasn't able to get what I wanted for my patients. So I spent about 5 years basically analyzing very critically all the problems I was seeing with the two-piece design. And it was, I wouldn't say easy, but I was able to pick up these issues, I think in large part due to my art and architecture background, because I was very detailed oriented about each square centimeter of these ears, and being very systematic with your analysis, you can find ways to move beyond and solve problems. So I'll take you through the problems as I saw them. Melting the implant basically eliminates the pores, which is the whole beauty of porous polyethylene, is that tissue grows into those little holes that are very microscopic, but it works. But when you melt it, then all these areas that got melted, you cannot get tissue integrating into these areas. But worse, it creates these connection points, and any connection point is a potential area that can fail. The other thing that always bothered me was that I felt like this rim looked so perfectly round, like it came, straight out of a machine, which it did, of course, but I wanted to make an ear look more realistic by having a rim that has all of the subtle variation in shape that a real ear has. Then there's the problem of the tragus, which is little but really challenging. It is a free-floating structure. It sits in front of and basically hides your ear canal, and it's very hard to reconstruct. And in my patients, I just felt like I wasn't getting the job done with the two-piece implant. And actually, when you look at that implant, the tragus was so poorly designed that we basically removed it every time and did a different technique to create a tragus. So this is what the implant looked like. The other issue has to do with the shape of the bowl. When you put in an appropriate sized implant for an adult, the shape of the implant bowl is too small and the wrong shape. Finally, well, not finally, this is number 5. It's nearly impossible to create a simulated canal. And that was true because there was no structural support for the tragus to provide you with a negative space for the canal. Number 6 is that the base of the implant is so tiny. I call it the ear print of the implant, and it's unstable and eventually over time can lead to collapse, not in all patients, but in some. So here's an example of a little girl, and you can see she had a prominent ear, which we were planning to tuck back. So we did a surgery for her. And here she is 4 months after getting an old MedPOR type of implant. And although they're not perfectly symmetric, they have the right size and projection that I was looking for. So I was happy. But 4 years later, the parents sent me a picture showing the ear that she did not have reconstructed, held up with its small otoplasty, but the other ear was collapsed into the head. So finally, that brings me to probably what I would consider the biggest drawback to this two-piece design, and that is that you can get fractures. And the fractures occur almost always in the helical rim, and although it's not dangerous, it does require surgery to remove this and, of course, replace it. And it's a risk that will last over your lifetime. So that's a significant issue and one I was very determined to correct. There's a little more subtlety to it. So I tried to strengthen the two-piece implant starting back in about 2013, I'd say. And I noticed the fractures weren't nearly as obvious, but you can still get subtle fractures, as you can see in the helical rim here. And even though they don't look so bad, and even though many parents might not even notice it, eventually they will worsen over time and eventually require surgery to replace. So in 2017, I basically made the decision, I cannot do these two-piece implants anymore, and I need to develop my own implant. So this is the very first generation of implant that I designed, and I called it a one-piece Lewin Ear implant, and it was made by Supor, and it solved some of the problems I was having. The rim was more realistic, and I was able to get an improved design of the tragus, and I was able to even get an improvement in the structure to create a fake canal, so to speak. And this is the first patient that got one of these implants before and after one operation. And here you can see when I compare his ear to a natural ear, the new implant, this new one piece in 2017, got a more realistic tragus and a more realistic bowl. So I was happy with that. And I felt like we were able to sort of simulate the shadow of a canal much better. And then I was really pleased with the back of the ear, something very few surgeons discuss, but I think is really important, because I was able to create the true space behind the ear. And of course, now we all know how important that is for masks. So the timing ended up working out really well, because patients with these one pieces are able to wear masks. So from 2017 to 2018, after using this for about a year, I took a look at sort of where I was at and noticed that realism improved. I did have one implant fracture that I actually just discovered in the last couple months. Just at that connection of the tragus to the rim was probably a little too thin, and it cracked right there. So we did have one fracture in this design, and only in the first generation, however. So the issue when I looked critically, though, is that I wasn't able to mimic how unique every individual's anatomy is. So here's a patient that I took to surgery, and we did a one-piece implant, and I was actually quite happy with his ear reconstruction and his symmetry, you know, even all the way around. I like showing a video that shows patients 360 degrees, so you can see every single angle. And here he is before and after. And here's a comparison view and a lateral view. And I did make the ear larger on purpose because he's growing. But if you look really closely at his ears, I noticed that small differences in the ears, like specifically here's the rim and the bowl, were slightly different shapes. And even the, what we call the anti-helix, or the Y of the ear, was slightly different shape. So I thought to myself, you know, what can I do to get an ear that more closely matches the non-Microtia ear? Because you can see these are all, you know, patients that have so-called normal ears that were born this way, and they all look actually quite different in shape. So I decided the first obstacle was that I needed to get a 3D image of the ear. And to capture that image, it needs to be relatively easy, inexpensive, and very accurate. So in 2018, very excited that I discovered the Artec Space Spider, and this technology is just amazing. We're able to scan in a few minutes in my office using blue light technology while the child is completely awake. And the resolution is incredible, up to 1/10 of a millimeter, and incredible accuracy as well. And I'm able to take this digital image and grow it up to the adult size if I'm operating on a child. If I'm operating on an adult, I actually shrink it down a tiny bit to accommodate the thickness of the flap and skin. So I modify the anatomy as I see fit, and then I custom design the base, which often relates to patients with hemifacial microsomia. And here's an example of how we can capture a complete video showing the entire head and both ears, and that helps us with planning for the best possible result. So I want to just mention that 3D scanning is the process of visually capturing a three-dimensional object. So it's a digital image. However, 3D printing is totally different. That's the process of making something, some physical object, from a three-dimensional digital model. I do not do 3D printing for this surgery. The Supor manufacturers use a different tooling to process in order to make the implants to my exact specification, but they are not printed. So then I had another obstacle, which is how do you make customized patient-specific ear implants? And they have to be, they can't be too expensive. Many people would argue it's too time consuming, and it's also not even necessary. So I was extremely happy to discover that Porous, who is the maker of Supor implants, was able to execute my design, and together we came up, after years of research, honestly, going slowly bit by bit, in how to make these implants. And they've been absolutely incredible in figuring out how to sort of make this process more quick and more efficient, even with respect to cost. So when you look at the beautifully complex anatomy of the ear, these implants can precisely mimic every subtle detail. And that's exactly what I was hoping to accomplish. So I believe I'm the first surgeon to establish this technique and use this technology, not just for an occasional ear, but really it is the exclusive technique that I use for every single patient in my practice since basically since 2019. This implant solves all the 7 design flaws I talked to you guys about for the old 2-piece implants, and then it also solved the problem in the first generation 1-piece. It's stronger, so that one fracture that we had, I don't think would be possible in this newer generation, and it's customizable. So far, our first case was in 2018, and we've done over 200 of these 3D Lewin ears. It is now the only implant I use. We've had no fractures, and I believe the results are much more realistic and symmetric. But I will say it's a lot more difficult than a 2-piece implant, and there was a very steep learning curve in doing these surgeries. And it actually, you know, I spent years slowly, modifying the technique to do it in a very safe fashion. So I just think people need to be aware that not all 3D ear reconstructions are the same. This is an example of a patient that requested a 3D ear similar to my technique from another surgeon, and they stated that they could do the same operation. So the patient went to surgery, and the parents were told by their surgeon that the implant was designed specifically for their child. This was the result after that surgery, and the family was very disappointed and not satisfied. So 6 months after this surgery, the family came to me requesting removal of this implant and placement of one of my 3D implants. So this is the implant that was removed from this patient, and you can see it actually bears very little resemblance to the patient's natural ear. This, on the other hand, is the implant that I used for his surgery. And here he is only 6 weeks after surgery because he went back home after that time period. But you can see even in such an early post-op, there is improved symmetry to the ear. And you can see that on this view as well. This was the 3D implant from another surgeon, and this was the 3D implant that I use. So now I'd like to show you the whole surgical process by following one child from beginning to end. So this is Wesley, who came from Connecticut to LA for surgery, and his local news station did a little story about him. I want you to watch.
What would you do if you only had one ear? Think about it. How would you wear glasses or a mask?
Yeah, and if you're a kid, how would you withstand the stares or the bullying? These are things 5-year-old Wesley Pierce of Wallingford doesn't have to wonder anymore, thanks to a California doctor's invention, building not just a new ear, but a new sense of confidence.
5 years of waiting and a 10-hour surgery 2,800 miles away.
And I'm going to make this little ear grow.
Have all led up to this moment for Wesley Pierce of Wallingford.
Am I ready to see this ear?
Born with Microtia, Wesley's right ear never fully formed. But using groundbreaking 3D scanning technology, Dr. Sheryl Lewin just made him a new one. And now it's time to see it.
What was that like for you as a mom in that moment?
Relief. Instant relief.
Relief for mom and dad. Comic relief for Wesley.
Open. It's purple. It's purple. It's funny because I've never had exactly that reaction.
That reaction now going viral and shining a light on this rare condition.
There's going to be another mom someday who's going to have the same condition, and there's more out there now, and he's a big part of that.
Awareness, Dr. Lewin hopes, will lead to a kinder world.
I love having the opportunity to give that to a child and a family, and I love to see their confidence bloom afterwards. But boy, wouldn't it be great if we are all just so understanding of differences that, you wouldn't even worry about that.
Thanks to her, Wesley won't have to.
I love my new ear.
So Wesley's big ear day was almost exactly 1 year ago, and I just want to take you through exactly what happens on the day that we do surgery. So all these cases are done in our operating room at Cove Surgery Center, and families get there very early, 5 in the morning. And around 5:30, I come by and say hi, and I answer any last questions. And by this time, the kids have taken what we call their happy juice. And it doesn't make them fall asleep, but it does take the edge off, much like a martini might affect us. So here he is.
Are you super drunk right now?
He's even got the hiccups to go with it.
Oh my gosh. Adorable.
So you can see he's a little drunk. Then it's selfie time, my newer tradition with my patients, very fun. And then around 5:45, I actually scrub into the OR, so I'm ready to start carving the implant even before Wesley comes in. And then about 15 minutes later, he is going to come into the OR and fall asleep just with this gentle, what we call mask induction. No pokes, no needles, no shots, just fall asleep breathing the giggle gas, as they call it.
Is that strawberry giggle gas? Yeah, it smells pretty good, huh?
So around 6:20, I get started with my analysis, and I use the non-sterile ear model to determine the proper positioning of the ear, and we mark that so we know. And then we go on to decide where the incision is going to be and mark the arteries, and then mark the area of the flap. And so this is the area that becomes the what we call TPF flap that will eventually cover the ear implant. Now at 7 o'clock, we actually start the surgery. So I am going to show a few graphic images from surgery. So if you don't like seeing things red, close your eyes because for the next few slides. It takes me, about 2 hours to do a few things with the skin and the earlobe and to get the flap out. So around 9 a.m., the flap is done, and you can see it's a very thin, very vascular piece of tissue. And I would call this the single most important part of surgery. It's kind of the key to success. And when it's done perfectly, you will get a very stable, healthy ear. So we also borrow some skin from behind the normal ear. You can see those white dots. It's actually from the back of the ear, and that's called a skin graft. And you can see we close up the back of the ear so you won't really even notice anything was done from that. And then by 10:30, we've gotten all our skin grafts. So the skin graft from the abdomen and low down leaves a low scar. Will cover the back of the new ear. And then the skin from both the Microtia ear and the non-Microtia ear are used to cover the front of the new ear. So here we're ready by around 11:30 to shrink wrap the flap, as we say. So the implant's put into proper position. We cover it completely with the flap, and then we apply suction, which allows us to get the exact shape of the implant. So here you can see Wesley's ear. When it's all shrink wrapped, we've actually started putting the abdominal skin in the back. And it's important to note that even though we took the flap from this area, we don't make any incisions in the scalp. And the only incision, which we're sewing up with our graft, is actually behind the ear. And then it's also important to know, and I think important for kids to learn, that we always save the little ear. It becomes the child's earlobe on their new bigger ear. So I often get asked if I take any break during the long day of surgery, and the answer is yes. I get a snack and I can use the potty. And while I'm out for about 20 minutes, the anesthesiologist and the rest of the OR team is taking care of the child, washing their hair, preparing for the next stage of surgery. And then when I scrub back in, I always take a moment to appreciate the trees, my favorite part of the OR, since I was able to help design the operating room. It was very important that I could see the shadows of the trees outside as they moved along over the course of the day along this translucent wall. So from 12:20 till whenever we finish is the time to put everything together. And it's very much like a sculpture, so I never know exactly when I will finish, but it's usually approximately 3 hours. And you can see how Wesley looks from the front view at the end of surgery. And here's the side view. And then 1 week later, you can see the ear's obviously swollen and bigger in part also because we made an adult-sized ear for him. But you can start to see there's a little symmetry there. And then kids always have crazy colored ears, pink and purple and bruised, and that's all normal at 1 week. So I assumed everything would have just gone smoothly. Wes would go home, heal beautifully, and maybe I wouldn't even see him again. But it's important to recognize that this specialized surgery doesn't always work out that way. And I think it's important that you see the rest of Wes's story, what happened after the news crew picked up and left, and they moved on. But of course, I'm still taking care of Wes, and I come to see this picture 2 weeks after surgery, and I see 3 areas that have little, like little areas of wound healing. And that's not unusual. And I honestly didn't really think twice when I saw these. But at 3 weeks, 2 of them went on to heal nicely, which they often do, but 1 seemed to get worse. And by 5 weeks, it was clear that we had what I call an exposure or a hole. So the question so many ask, does this mean the body has rejected the implant? And the answer is no. Only living tissue can be rejected. So like a kidney transplant or a liver transplant can be rejected by your body, but an implant cannot be rejected. So what people, I think, call rejection is really an exposure or a hole, and that's where the implant is visible. And honestly, the exposures really don't have much to do with the implant itself. They're almost always tissue flap issues. So that the flap had some problem in that little spot that it didn't live, and then the skin above it can't live, and that's how you get the hole. But if that living membrane flap is done absolutely perfectly, you will have an ear reconstruction that will be durable and stable. But a certain percent of the time, you have these little bumps. So he had to come back to surgery to fix this, and I had several ways I could have gone, but I opted to actually remove his implant. And so, believe it or not, this is actually the earliest after surgery that I've ever removed an ear implant, only, 5 or 6 weeks out. But the flap was strong and everything worked out fine. So we put a new implant back in and repaired the hole. And I will tell you that this is my motto with ear reconstructions. They just take their own sweet time to heal. So I will be reminding my parents that we just have to be patient with this ear. So 9 months later, here's Wesley's ear. And I feel like it's, pretty hard to see where his exposure was. And I don't feel like, this bump in his road really had an impact on his ultimate result, but certainly it was very stressful. There's one additional point I wanted to make about Wes's surgery that's, relatively a new development, and it has to do with his prominent ear. And I knew his mom wanted me to tuck it back a bit, doing an otoplasty. So for his implant design, I decided to do a virtual otoplasty and, on the computer with software, create an ear that was what I thought would match my otoplasty on this side. So here you can see him now 9 months after his second surgery, and he's got pretty good match of the projection of the ear. Here's a different angle to see. And here's his other views. So I think probably, my single greatest, thing I'm proud of is my ability to navigate when there are bumps in the road and to strategically plan an elegant solution for, what's often a very difficult problem. This is a screenshot from my website, and it just shows that I have an entire, portion of the website dedicated to risks. And I go over in good detail just what all the risks are. And I think that, I easily could have sort of not given you that middle segment of Wes's story, and probably nobody would know what he went through before he got to his results. But I think it's so important for families to understand that, we just don't have ultimate control, and little things can happen. And when they do, it's just most important that you have a surgeon who's going to hold your hand through that complication and, stick with you the whole time, no matter how rough it gets, until you get to where you all want to be. So how does the 3D ear heal? I'm going to actually, try to bring home the point that everybody heals differently. And in addition, how you take care of the ear after surgery is super important. So here's before surgery for two different patients. And after surgery, it's pretty similar. And even at 1 week, looks very similar. But you can see by 1 month, these two patients have very different sort of innate healing capabilities. And so this is where that have patience thing has to take hold. A month later, one ear is looking quite good, the other ear not so good. And it's hard to make progress. But again, if you just are patient, you can see by 6 months, it's not done healing the ear on the right-hand side, but it is much, much better. And the other patient has longer out from surgery. So I have him even at 1 year and at 2 years. And even at 2 years, I feel like the coloring of the ear, the scars don't disappear, but the coloring of the ear improves. So I want to take you through some results of 3D ear reconstructions using the customized PIER implant. But first I want to talk to you about photographic standards in plastic surgery. So all surgeons get taught about these standard views, a frontal, an oblique, the lateral view, and I use a worm's eye view, which is very important. And these are accepted and published by the American Board of Plastic Surgery. And I guess it's my pet peeve that all surgeons take these photos, but they don't all show you these different views on their websites or in their examples. And I think it's unfortunate that that is the case, because only certain views are shown. And in my opinion, they tend to be the views that kind of look the best. I don't believe in that. I show every view for every patient that goes on my website. And it's so you see an actual real result, because they're not perfect and they have asymmetries and they have visible scars and they have color differences. And I think those are important to see. I also think it's important to show the opposite ear. This child has a pretty sizable big ear, and you could do a beautiful ear reconstruction, but if it's not matching the size of his ear, then it's, significant that you would need to know that. So here he is. We'll talk about him a little bit later. The first patient has a grade 2 microtia with a low canal, so that's a little bit tricky to deal with, and I'll show you her. You can see she also has hemifacial microsomia, and you can see that in her line of her eyebrow and line of her eyes. And then if you look at her ear canal in the front view, you can see where it lines up relative to her nose, but the opposite ear canal is higher. So this presents quite a challenge and very difficult to overcome it completely. But here she is after one operation, and you can see she's got nice symmetry to her ears, but it is a little bit lower. Here she is from the worm's eye view, and you can see the difference in her facial structure with the hemifacial, but then when you put the ear on, you can help create improved symmetry. Here's her other views, lateral view. So to learn more about hemifacial, I have an entire live chat, presentation just for patients that have this condition. And if you want more information, visit the website for that. Here's grade 3 microtia reconstructions now. So here's a patient 8 months after surgery. You can see his front view, the worm's eye, before and after from an oblique and a lateral position. Another patient, she's 1 year out here in this picture. And here's her oblique, lateral, and comparison views. And what you see is that even 1 year later, there tends to be improvement in particularly the color of the skin and the quality of the skin, and a little bit even the scars. Here's her lateral view 1 year out and 2 years out. So here's bilateral grade 3 microtia. And even bilateral patients get a 3D implant. It's taken from a real patient, and I do several modifications to fit the patient that I'm taking care of. Here's one of my bilateral patients, and here he is 1 year out from surgery, a little over 1 year out. You can see his views, a comparison view. And I also wanted to point out, there's smaller bumps along the road, and I find this particularly in bilateral patients that are tiny or young when I take them to surgery, is they tend to get hair loss. And here he was 2 months after surgery with quite a lot of hair loss. And then 1 year later, obviously you can see everything's grown back. Grade 4 microtia is the very hardest one that I treat. And here you can see this patient who has not just anotia, but she also has hemifacial microsomia on this point. And here she is after one surgery for each ear. She has a low hairline, so we have to take that into account. And here's her anotia side, and then her grade 3 side, and also a little bit of alopecia or hair loss that grew back. So the concept of one and done, even though these last 5 patients only required one surgery, is one that I don't let people prescribe to, because you can just never control sort of all the little factors that occur in surgery. And sometimes you're going to need to do additional surgery. Here's an example of a patient like that, who, here's her post-op view, like a few months post-op, and I split it in half because she looks pretty symmetric there. But we did tuck back that ear a little bit. So now when you look at her, one ear is closer to the head and her reconstructed ear is actually more prominent. So we did need to do a surgery to address that, which you can see how significant it was. And it was relatively simple to do and create an improvement in her appearance. So here she is, after her second surgery on the right side of the screen. You can see we got better symmetry. And here she is in a comparison view, and up close, you can see we got nice symmetry from all angles, even the back. Here's a patient who also required a second surgery. She has hemifacial microsomia, as you can see. And here she is after her first surgery, and she did quite well, but there was an issue with her earlobe right here. And I'll try to show it to you in this view. After her reconstruction, she looked quite good for the upper 3/4 of her ear, but when you looked at her earlobe on the 2 sides, they didn't match, and the earlobe on the reconstructed side was being pulled backwards. So we did a little surgery to bring it forward, and you can see her result there. This is a picture I took in Botswana, and when I was photographing animals there, it dawned on me that capturing ears outside of a medical photograph, just in their natural environment, is probably worthwhile for patients to see because there's no controlling of lighting or filters or any of that. So real briefly, I'll just show you several of my patients, all of whom had 3D ear reconstruction, so relatively recently in my career. And it just shows you sort of what we can accomplish with this technique. My baseball player, bilateral patient, really tricky actually. There's some candid photos his parents sent me. Another patient, similar view. Little puppy kiss. So now we're going to switch gears and talk about the complications that can occur with porous implant ear reconstruction. So I'm going to present to you my complication rates, and that's after 522 consecutive, what I call first-time patients over the last 8 years, meaning I don't count anybody who's had any prior surgery to their ear. So the most important has to do with exposure, and I have a 7.6 overall rate that you can get an exposure. Fractures was 7.4%. and bleeding 2.1%. The reason I call these most important is because all these require going back to surgery. The most treatable complication is typically an infection. So even though they look scary, and this was seen 10 days after surgery, after just 1 week of oral antibiotics and a topical antibiotic, we were able to clear things up very quickly, and 10 months later, you can't really tell. And then there's very rare complications like a nerve injury, a vascular injury, which fortunately in my career I have not had, and what we call failure of PIER, where something happens that's so terrible that we have to remove the ear completely and you basically start from ground one. So I was curious, what about these 3D ears? Is there any differences? So I did separate out my 200 3D ears, and there's a slightly smaller exposure rate, probably not very significant, but the real significance is there's been no fractures. And even, the other incidents of complications for the moment are a little bit lower. Again, I doubt those are very significant except for the fracture. I have more detailed information on these risks, again, in another live chat available at the website. So I do want to quickly say, how do we treat a fractured implant since you have to come back to surgery? So here's one of my patients about 1.5 years after surgery, and then 3.5 years, you start to see that the ear's kind of sitting closer to the head. It's that ear print issue of the base. And you can see there's a fracture in the rim. And here's what the implants look like, the one we took out and the one we put in. So here's his before surgery picture. And here he is after healing with his new 3D implant. And you can see quite a big improvement in symmetry. So now I'd like to go through a few frequently asked questions to finish up the talk. What's the best age to have surgery? I submit it's 4 years old. And I have a lot of reasons for that because they seem to have less anxiety, less pain, less teasing and bullying, greater self-esteem, better acceptance of the new ear when it's done before kindergarten. And this is the one that's, just hard, but, I'm just finding it to be accurate in my results, that basically I can get a better result when the kids are younger. So I just want to kind of explain why. These are all 4-year-old 3D ear patients of mine. And these are 8 and above 3D ear patients. Some are adults. And if you want to know why, there's a difference, it's really, you can still get a beautiful ear. It's just the level of detail and definition is what I believe is different. And I want to explain to you why that difference occurs, but it does involve a graphic image coming up now. This shows 2 flaps. So the flap of a very young child who's got thin detail to the ear, that's the image on the left, and the flap of a 13-year-old boy, which is thicker, and you can see right away just doesn't have as much detail. So that thicker flap, when it heals, leads to some differences in how the ears are. But I also think it's important to understand, you're not ever going around comparing kids of different ages. You're just looking at the other ear. So here's that same 13-year-old child who, after just one operation, I think has a very, very nice results, and he looks quite symmetric to his opposite ear. And if you accomplish that goal of no one noticing your ears, then this fact doesn't really matter. Does the PIER ear grow? No, it does not grow. This shows growth of ears from 4 to 7 years old. 83% grown adult size at 4 years, 90% at 7. So we take that into consideration. Here's an example of a patient from a long time ago, 5 years old. And here he is after having one surgery with MedPOR. This is many, many years ago. And you can see that his ear is quite a bit bigger than his opposite ear. And he lived in another country, but he came to visit me 5 years later. So we took pictures again, and we could see that he kind of grew into his MedPOR ear. And at this point, he won't be growing anymore. Can you feel your PIER ear? The answer is yes. And I'm going to show you a bilateral patient. We had done one ear 2 weeks prior to this video, but his other ear several months prior. So I'm just testing the other ear.
Okay, Mr. Kaiden. How old are you?
5.
You're 5? Okay, so did I help you with something? No! Where did these come from? I'm just kidding. Okay, we made this ear, what did you say?
End of March.
End of March, so what is that, 4 months ago-ish, 4 months ago. So I'm gonna ask you some questions about this ear that you've had for 4 months now. Okay, so turn this way. So, do you feel me touch your ear lobe? Okay. What about up here? You feel?
Yeah.
Okay. Back here? Okay.
So kids actually get to feel their ears. It's never going to be the same as like, your normal ear, but they do have sensation. I get asked this question, does the flap grow back? It does not. I kind of think of these flaps sort of like your appendix or your gallbladder. They can require being removed from your body, and your body doesn't need it or miss it, but it never grows back. When can sports be played? We let kids go back to all activities except boxing 6 weeks after surgery. I never recommend boxing, sorry. So here you can see we have so many wonderful Microtia athletes here, and I never get tired of seeing this video. This is one of my patients who's a world-class tumbler, and he did an international competition only 7 weeks after getting surgery. Here's a practice for him. Don't think these Microtia kids can't go on to accomplish whatever they want. Really amazing. How durable will the ear be? I'm going to let Brennan be my model here. Again, this is a MedPOR from many years ago, but I love the video because it's cute.
The temporoparietal fascial flap that sits on top of the implant actually is mobile over the implant. So you can see that the skin moves all over, even though the implant stays the same. And similarly, the ear can move and come off the head or move back, quite mobile because it's not fixed to the scalp and it doesn't hurt. Right, Brennan?
So if you do the flap properly, you can protect little scratches or bumps, or this opened up, we just butterflied it and it healed in a week. Here he is 3 months later, you can't even tell. Flaps swell for all kinds of reasons, usually mosquito bites. You just wait, they get better on their own. We never, ever, ever put ice on them. How long does a porous implant last? Well, 30 years and counting since the first porous implant ear reconstruction was done in the United States, at least 1991, and more than 40 years when used in other parts of the body. What's really important to know is that the living membrane flap and the skin are your ear's own natural tissues. So you can always basically reuse that tissue. Even if a new implant comes along, you can take out the old, put in the new, and save all the rest. This is a patient who is 20 years after her original MedPOR surgery, which I did not do, but her implant fractured. So we replaced it with another MedPOR. At the time, that's what we had. Do I do surgery on adults? Yes, I do. And here's an example of a 38-year-old woman about 3 months out from her surgery. 49-year-old woman. I feel like the women get better definition than the men. I mean, maybe because they're not as muscular. I'm not sure. How does Atresia repair affect PIER? So the timing is important. You have to do the canal first and the PIER after. There is a difference in complications. We see an increased rate of fractures in our patients that have had canal surgery. And then the appearance is less realistic. So it's just good to know that going in, that when you get an Atresia repair, it starts out as a big black hole. And, you know, when you look at a normal ear from the side, you never see an ear canal. It's just skin of the bowl. But in order to see the canal, you almost have to look from behind and see that shadow of the canal. So when you do a 3D Lewin Ear implant, so no Atresia repair, we try to mimic that shadow so that it looks like you have a canal. But this is a patient who had Atresia repair and PIER afterwards. And you can see he has nice symmetry and a very nice ear reconstruction. But you can see the Atresia repair is very obviously, you know, very, very dark. And if you could cover it just magically with the power of Keynote with skin, you can see that the ear reconstructions look quite symmetric. But without that little trick that we do, it is sort of a telltale sign that it's a reconstructed ear. Can I get PIER if I'm unhappy with my rib ear? In most cases, you can. So here's a 9-year-old who had 4 rib surgeries, did not work out. We did 1 3D surgery for her and double pierced her ear. She was super excited about that. Older gentleman, failed rib times 3, and here he is after 1 surgery. Can I swap out my old 2-piece implant for a 1-piece 3D implant? The answer is yes, and more of my patients who are finding asymmetry with their 2-piece implants are opting to do this. So here's an example of a patient like that who had right microtia. We saw him earlier, and here he is with his 2-piece implant, which looks very nice, and it's a very nice ear reconstruction. From side view, this is why it's important to show all views. You can tell here that it's collapsed against the head because of that instability of the 2-piece. So you can see that right here. So we did a 3D design for him, and here's his original 2-piece implant. And here's his new implant only 1 week after surgery. You can see immediate improvement in symmetry. And here he is many months later, maybe even a year later, I can't recall exactly. You can see his comparison views. And we're able to do this using his own flap, his own skin, no additional scars even, just take out the old, put in the new. It's not quite that quick, but can you do a 3D ear and a hearing implant at the same time? Yes, we do all variety. Pontos, Bajas, Osseas, Bone Bridge, and Sound Bridge have to be done after. I can do them at the same time only for those others. What advice do you give Microtia families? So I feel like it's really important to have virtual consults, and that way you can literally talk to people all over the world who are potential surgeons for you and get everybody's opinion and educate yourself. I think you can't underestimate how important it is to talk to other patients. So find patients in some of the Facebook groups, or the doctors can refer you to patients that have that they have operated on, but find an ear pal, even at some of these conferences, so you can compare notes, help each other through, be supportive. I think it's important to be very critical and make sure surgeons are showing many different results, that they show them from every angle, that they include close-up views and details so you can see scarring, and, you know, be a little skeptical if only a couple examples are shown or only shown from certain angles, and ask yourself, why are they hiding that information? I think it's important to really find people that, you know, have done a lot of these ears and can show you exactly what they can accomplish. Things have just completely changed in my practice over the last 4 years since I've started using these implants, and now that all that I do are these surgeries, it's really helped me climb that learning curve, although, like I said, I'm still not at the top. Trust your gut. I feel like you're going to know when you've gotten to the point that you've done your research, and no matter what decision you choose for your child, or to do nothing at all, you will absolutely know the right path to take. So also, education is critical. We developed a series of live chats. We have a whole bunch of different ones on our website. I think they feature different speakers and can help give you some information that might be helpful. Last question, why are you the happiest doctor? It's because every Wednesday I get to show kids 3 times a week. I get to show them their new ears, and probably one of them.
Let you see your ear, and remember, big, chubby, pink and purple ear. Okay. Open.
And that's beautiful.
Oh my God.
So not everybody's happy, I can tell you. He was very, very grumpy, this little guy, and I tried my best, but he was not having it. But his sweet parents, 3 weeks later, sent me this video.
It's beautiful and I love it.
And this is a classic, our most enthusiastic and polite patient ever.
I have 2 big ears. Thanks.
Aww.
Wow. I got so much ears.
Yes, you do.
This ear is awesome.
So that is it. Thank you so much for your attention, and really appreciate that I was able to help talk a little bit about what I enjoy so much.